Um, this portfolio is a partnership between Grand Challenges Canada, but also the UK Foreign, Commonwealth and Development Office and Global Affairs Canada. So in case you don't know a lot about the work that we have been doing for the past, I think, 7+ years in this space, through this unique portfolio, we've supported 100+ innovations, seeking to save and improve lives in the most complex, conflict-affected settings, and seek to transform humanitarian response efforts. Really focusing on global challenges around the topics of humanitarian health, access to energy, water and sanitation, and access to life-saving information in conflict settings. So during today's session, we're going to cover a lot of ground. So stay with us. It's going to be a great conversation. So first, we're going to hear from Her Royal Highness Princess Sarah Zeid of Jordan, who is going to situate us in the global burden of maternal newborn health issues in crisis settings. After that, we will welcome 4 promising innovation teams who will showcase their work that is at the bleeding edge of innovation to address critical maternal, newborn, and other health-related challenges. And from there, we're going to move into a panel discussion with these innovation teams to learn more about how these innovation teams are unlocking opportunities and thinking about their value networks in the sector and addressing some of the challenges that many of you, I'm sure, know are part of operating in some of the most complex emergencies. And from there, we're going to try and make some time for Q&A with the panelists and the audience here. So this is a hybrid session, so welcome to those who are online. Thanks for joining us. And now, without further ado, I'm really honored to welcome a very special guest who is a good friend of GCC today's session. Her Royal Highness Princess Sarah Zeid of Jordan is an advocate for women's newborn, child, and adolescent health, nutrition, and well-being in humanitarian and fragile settings. As Special Advisor to the UN Emergency Relief Coordinator Special Initiative on Maternal and Newborn Health in Crisis, Princess Sarah champions efforts to reduce preventable maternal and newborn mortality and morbidity in fragile and humanitarian settings. She is also Special Advisor to the World Food Programme on Maternal and Child Health and Nutrition, a UNHCR patron for maternal and newborn health, and convener of the roadmap to accelerate progress for every newborn in humanitarian settings. Princess Sarah supported efforts to reduce maternal, child, and newborn mortality and morbidity, and championed the health, well-being, empowerment, and contribution of girls and women in fragile and humanitarian settings. Princess Sarah also led Every Woman, Every Child, Everywhere, an unprecedented global multi-stakeholder movement to integrate humanitarian and fragile settings in the global strategy for women's, children's, and adolescents' health, a roadmap adopted in 2016 by the World Health Assembly to end preventable deaths of women, children, and adolescents by 2030. So please join me in welcoming Princess Sarah, who's going to open up the floor with some opening remarks.
Thank you very much. And we should note first and foremost that obviously I've been working on this issue for a very long time, and tragically made very little progress. And that is one of the great frustrations, I think, is that we know what the problems are, we know where they are happening, we often know how they are going to be resolved, and we have to infuse into all of our conversations and our actions and our activities a real sense of urgency, and you know, the innovation work is fantastic, and so I'm really honored to have been asked to come and to speak and to be with you all. And I do have a script, so I'm going to get on with that. But thank you very much. Good afternoon, and thank you everyone for joining us online and in person. We want to also acknowledge those that are not on in person with us today. The Sahat Kahani, who despite the best efforts wasn't able to join, and sadly in these terrible times I'm sure they are not the only ones who have been able to be with us. Around the world, women and girls are battered by forces they cannot control, prevent, or escape. Conflict, displacement, economic instability, and unchecked climate-related shocks are uprooting and destabilizing millions. In fragile and crisis settings, health systems fracture, infrastructure collapses, supply chains break, schools close, and access to life-saving protection and services fade away. However, the death and injury of mothers and their newborns are not inevitable in any setting. They are predictable consequences of neglect. Fundamentally, maternal mortality is a measure of justice and a reflection of how society, how we value women and girls. So how are we doing? According to WHO figures, in 2023, over 60% of preventable maternal deaths occurred in humanitarian settings. And for every death, there are untold numbers of near misses and women and girls left with life-altering injury. In humanitarian response, maternal and newborn health is treated as secondary, something to be addressed once if food, shelter, and security are in place. Innovation is not only about advanced technology or sophisticated laboratories. Innovation at its heart is about reimagining and re-energizing how care is delivered and needs are met. It is about asking, how can every mother, every woman, every girl access the information and qualified, respectful care that she needs and should have? Too often, solutions are designed for stable environments and only later adapted, if at all, for humanitarian contexts. Too often, the women facing the greatest risks are last to benefit from new ideas, new tools, and new investments. If we are serious about saving lives, innovation must be designed with crisis settings in mind from the very beginning. Solutions that are durable, adaptable, and scalable in fragile contexts need to be properly funded, flexible, predictable funding, and innovation must be affordable and accessible for the communities that need them most. Ultimately, the measure of success will not be in the number of technologies we develop, nor the number of reports we produce. It is simply, did a mother survive pregnancy and childbirth? Did a newborn baby take their first breath safely and thrive? Did a family in the middle of crisis experience not tragedy, but hope?
Thank you, Princess Sarah, for shedding some important light on why we're all here, the growing burden of maternal newborn health challenges, and for really underscoring the importance of innovation in crisis settings. I think we often forget, innovation has become a bit of a buzzword, and that crisis and conflict is really a really important place that we need to be doing better at in terms of driving and scaling innovation. So thank you for driving that point home today with us. So from here, I'm going to pass the mic over to Ian Gray from Gray.Catalyst, who's going to also provide some framing around the next few segments of today's session.
Brilliant. Thanks, Zaina. Hi, everyone. So we've had some great remarks about the need for innovation, particularly when it comes to maternal and newborn health. And I'm going to provide you with a little bit of a framework to think about part of that innovation journey and the role of value networks. So I'm going to spend a little time on that, and then you get to hear from the people who are actually scaling their innovations and actually having significant impact on lives across the world. So my name's Ian Gray. I'm founder of Gray.Catalyst, and we are the innovation support platform provider for the SHIC program. So we've been working with Grand Challenges Canada for a couple of years almost now, which has been good. So yeah. What I want to talk about is value networks. I want to do it through the frame of, family planning. So very much linked to maternal and newborn health. And there's around 190 million women who don't have access to contraceptives that they can be in control of around the world. Many of them are in refugee or IDP settings or in very remote locations. And so some of you may or may not have heard of Sayana Press. About 10, 12 years ago, I was working on this with a client when we were thinking about how do we get this to scale. And what it is it's a subcutaneous injection that can be self-injected to provide months worth of contraception for a woman. So where did it start? It was thought of initially for DMPA in terms of the contraceptive to put it into a single dose syringe. And that was in 1995. So what you'll notice is this is a very long timeline, and that's what scale journeys are like. Proof of concept was another 10 years away when actual efficacy was proved. And then it didn't get regulatory approval for another 6 years. And then after that, first country where it was launched after its trials was in Burkina Faso. WHO came in with their policy recommendations saying, yep, we're happy with this, moving forward. And by 2019, it scaled to 30 plus countries with hundreds of thousands distributed of this contraception. And what it allowed was not having to access a health clinic every month. It allowed you to self-inject at home wherever you are. So really interesting innovation, really impactful innovation, and it's scaled towards the end fairly rapidly. Where you can see the long gestation time of what it takes for health innovations to scale. So how did it scale so successfully? There's lots of reasons, but the one I want to focus on is the value network part of that. And so you might ask, what is a value network? So many of you will probably have heard ecosystem already today in a session. You've probably got a little bingo list of things: localization, ecosystem, systems thinking, those kind of things. A value network is thinking about an ecosystem through the lens of what value it creates, rather than who are the actors within this. So it's really concentrated around the value. And this comes from a book I wrote with Professor John Besant around scaling value. And what we noticed in our research and in our practice was there were a number of value roles that were held by entities. So I'll explain what that is. An entity, we don't talk about stakeholders. We talk about entities because it can be organizations, it can be individuals, but it also can be digital and physical infrastructure. There will be lots of people working on products and services in this building now that will be thinking about agentic AI. We'll be relying on mobile network coverage for internet access and those kind of things. They're all things you need to think about as you're scaling to new regions. So that's why we talk about entities. The other reason we talk about entities is they take on roles. So it's not just this is the Ministry of Health. The Ministry of Health will be playing certain roles, and you need to be aware of what they are. And we've found that there's 9 roles in general that are played the most often within these kind of value networks. So going back to that then, we've got one role, which is a creator role, and they are people, organizations, and stakeholders and entities that create new value in an innovation process. So what does that mean? For Cyana Press, it means that there were 2 types of these. There were the inventors, so Pfizer were those who had the actual drug, and Path were those who designed the Uniject device. But it also needed investors. So you had Children's Impact Fund Foundation, DFID as it was then, Gates Foundation, USAID, all providing money into that innovation to support that innovation. But it also needed what we call conveyors. And conveyors are not the same as channels. Conveyors are how you reach the end target group or impact group, and they add value as you go along. So often when we're working with innovations, they're thinking about a Ministry of Health, they're thinking about a local NGO, etc. But they're not thinking enough about what's the value add that they bring. It's not just to deliver. And in this case, you had UNFPA, Ministries of Health and local partners, who are all part of the training process to actually train health workers on how to work with women, on teaching them how to use the device, how to use it safely, how to dispose of the injectable safely, and so on. So they were really needed as part of that value network. But the thing that we also impress with startups and innovations that we work with is each of those entities are likely to be playing multiple roles. Too often we go in and think, actually, this is an NGO. We need to partner with that NGO without thinking, actually, what roles are they playing and is it more than one? And so to give an example, one of the roles that we talk about is a cartographer. So they are people who set the boundaries of how much value can be created. It can be anyone from a religious leader, community leader who says you can't use this innovation in our community, through to regulators and unions and the like. So here we had WHO. The WHO recommendation was critical for adoption by ministries of health. You had regulators. Without regulatory approval, you couldn't go around willy-nilly passing these little needles out for people to stab themselves with. And then ministries of health, you needed them to actually say, yeah, we will use this and condone it within our ministry. And so what you've already seen is the Ministry of Health was playing both the conveyor role, because they were helping deliver and train, but also they were playing a cartographer role because they were saying whether it could or could not be used. And so thinking through multiple dimensions with any kind of entity is really critical in the value network. Another key role in lots of value networks are coordinators. You've seen all the different entities that were engaged so far. They didn't just happenstance together. It took a coordinator to bring them together. And you'll see PATH played that role. So PATH not only invented the Unijet, but they also drove the whole of this scaling journey by coordinating all the actors together. Finally, the third thing to think about with roles is they change over the innovation cycle. And so what happens is you might be engaging with a partner, for instance, in the early stages of your innovation, and that partner's role may change or disappear altogether when you come to scaling. So when it came to Cyana Press, we did have this changing role. And what was interesting is you saw all the investors at the start. I won't name which one it was, but a number of those investors could make the journey from being an innovation investor to essentially a customer or a consumer. And so what they became were buyers. And what they were able to do within their organization was say, actually, we will do forward purchasing. We will do market commitments to say, if you deliver the right price point with the right efficacy, and it's being passed by regulators, we will commit to buying X amount of these from you, which opened up that scalability for the producers. And it was really important. But what was interesting, of all those initial investors, there was at least one who couldn't make that journey. Because for them, their internal requirements were that they needed to go to an open procurement process. I see some nods and people who have been involved in that, where early on, you've got this kind of creator relationship where you're going through that and creating that innovation. They're investing in it, but once it comes to scaling, suddenly you're in an adversarial open procurement process. And so some of those early kind of creators and investors could take that journey and others couldn't. So what's really important to understand is the value networks are absolutely essential for the scaling of any health innovation. Without them, you're not going to scale them on your own. Everyone who's going to present to you today is in some kind of partnership, multiple partnerships, reliance on others for their scale journey. So that's what we wanted to do, is just give a little bit of framing, give a case study looking backwards, and we're going to spend the rest of this session looking forwards, and we're going to hear from those who are on the journey as we go. So we're going to have some presentations. We're going to have 4 innovations all present, and then they're going to have a bit of a panel discussion with Zaina. So, as we heard, one of our group couldn't make it, so you can see Sikandar on your screen. Sikandar, you might have to talk quite loudly for everyone to hear, but Sikandar's from Sehat Kahani, and he's going to talk us through what that innovation is and what they're doing with that innovation. So over to you, Sikandar.
Thank you so much, Ayn. I think, am I audible? Is it loud enough? So, hello everyone. My name is Sikandar Khan, and I'm the head of finance and investments at Sehat Kahani. It is a company that has been founded by 2 female leaders, Dr. Sara Said Khurram and Dr. Ifat Zafar Aga, who are doctors by profession with more than 20 years of experience cumulatively in the health industry. They identified an opportunity in the healthcare sector, next please, where there is a significant disconnect between doctors and patients. In Pakistan, less than 0.5 doctors are available for 1,000 patients. 50% of the population lack healthcare access. 36% of women never see a doctor in their life. 40% of children have stunted growth, but now we see that as the time moves, the smartphone penetration is increasing with an 85% teledensity. So, in this opportunity, these two leaders founded Sehat Kahani, which is a comprehensive digital healthcare platform connecting patients in need of quality care to online doctors via affordable, convenient, and easily accessible technology. In the Sehat Kahani ecosystem, we have e-health applications and e-health clinics. Through e-health application, we are catering to different segments of population. It does not only provide consultations, but it provides mental wellness sessions. It provides OPD management solutions. It provides cashless pharmacy and home healthcare for patients who cannot go to the hospitals. We have established e-health clinics across Pakistan in underserved areas. Since 2017, with the help of 7,500 healthcare professionals, we have served more than 1,200 corporates and established more than 80 e-health clinics. We have reached 11 million lives through 2.5 million users and provided them with 4.6 million consultations. Next, please. All over Pakistan, we are currently operating more than 80 e-health clinics with our power partnerships in both private and public sector organizations. We have been working on basic health units and delivering maternal and sexual health services with federal and provincial governments. To date, we have done, next please. To date, we have done more than 1 million consultations at these e-health centers. And very interestingly, out of these 1 million consultations, 88% consultations are done by females. And 25% of these are related to maternal and sexual health cases, whereas 5% relate to newborns and infants. As we scale up the impact and move to commercial markets with the specialized technology, we are scaling our e-health clinics to Africa and our B2B model corporate application in Pakistan, whereas in the GCC region, we are scaling our corporate application. In Pakistan, we are on our way to becoming national telemedicine carrier of the country. Next, right? Partnering with the Ministry of Health and working with them on a tender worth PKR 3 billion, which is equivalent to $10 million. As we move forward, in Kenya, we are launching 2 e-health centers in conflicted and humanitarian challenged areas by mid of July 2026. And we have launched our commercial operations in UAE with e-health application for corporates, where we are targeting 1.2 million lives. As we move forward, on the next slide, you'll see some of the awards and recognitions that we have done and some publications, which are related to different healthcare segments. In the next 5 years, we are looking to generate more than $750 million in value and reach more than 100 million lives through 30 million users, providing them more than 230 million consultations. Thank you.
Sikandar. Next, we're going to hear from Ogo Health.
Hi, everyone. My name is Khalid Hashi, and I'm the founder of Go Health. So before I begin my presentation, I just wanted to start with some grounding in terms of who I am. So I entered the humanitarian and development space in 2017. I entered in a very unconventional way. I went to visit my grandmother. So this would be my only living grandparent and the first grandparent that I'd ever get to meet in a country that I've never seen before. My parents are from Somalia, and I'm Somali Canadian. And It was there that I met my grandmother over very difficult circumstances, over a medical appointment, and I realized that she did not have her records. And that's when Ogo was born. Ogo means to know in the Somali language. And we began with a commitment to ensure that every mother and child has their records and that the health system would remember. So this is a photo of what a typical maternal and child health clinic looks like in Somalia. Does this photo resonate with anyone? Have you seen these very bulky, hard to read papers that often get lost or
Faded.
Sorry?
Faded.
Faded. Usually like a district or regional health officer would go and pick up these paper registers and then take it to a government office to then aggregate them. And what we've done is innovated the solution and the process. You can see off to the far right-hand corner, health workers are now able to determine who is coming to the clinic to support what they're planning, but also to issue follow-ups. And we'll talk a little bit about what that innovation looks like in a second here. This photo was actually taken at our very first pilot in Gergad facility, who close to 10 years later are still using the system today. So Princess Sarah mentioned earlier the urgency of acting now, and I just wanted to frame this in what these numbers look like in Somalia. Nearly 2 million children under the age of 5 are severely malnutrition. 1.5 million have never received their first vaccination, and less than 4 doctors for every 10,000 patients, and that's 1/10 of the required World Health Organization requirements. What our innovation is doing now is we are not only strengthening health systems, but we're really centering it about children. So we have digitalized every nutrition facility in Somalia alongside UNICEF. And what that looks like is ensuring that from the very supply side to the very last mile, that we're able to track the RUTFs to mothers and to children. We also integrated smart logic tools. So we know earlier we were mentioning that for every 10,000 patients, there's only 4 doctors. So we've created smart logic. So you just incorporate the height, the weight, and the system is able to provide you the recommendations of the Ministry of Health, but also ensure that we're able to do referral pathways if there are stabilization centers or better pathways for care. Health workers determined that 80% of health workers using the system reported that it's been easier and more efficient in their everyday workflows. We also implemented our immunization registry, which began when we first implemented in 2017. Today, that's now supporting 300,000 mothers and children, where we could track every single vaccination and the message goes out to the mother in both audio and in text format, requiring and tracking to see if a community health worker needs to go knock at that child's door. What's really interesting, we're talking about partnerships, and often when we talk about partnerships, we think about large UN agencies, but it was really the partnership with our diaspora community that actually funded our very first pilot. We raised $10,000 and started selling these $10 pins many, many years ago. And I went to Somalia with 2 Toshiba laptops initially, and I thought, really, we had this amazing idea that we'd taken ground. It was then partners like UNICEF that seen the innovation in a real life setting that helped scale the work. And today, over 45 local and international partners have adopted the solution. And it was the Gates Foundation, actually, Open Ideal Leaders in Human-Centered Design Thinking, that funded us to travel across Somalia to really iterate our process. And we were able to really record our messages in different dialects and scale the impact of that immunization program, which later now transformed to the government adopting and scaling the playbook that we've implemented then. Ooh. So through a lot of these partnerships, whether it's the diaspora communities that we were mentioning, Grand Challenges Canada, who came in midway through our innovation journey, We initially were working with the Response Innovation Lab, who is an ecosystem marketplace partner who noticed a challenge of World Vision, that they were looking for an innovative solution to reach more children quicker. Response Innovation Lab partnered us up with World Vision and later Save the Children Action Against Hunger. Of course, UNICEF that I mentioned earlier, and we'll talk a little bit about that in our panel, came on board, but it was really the government that really streamlined this in their workflows and was able to help us accelerate our impact to now reaching 1,000 maternal and child health facilities across the country. 500,000 children have been reached to date, and we're supporting a task force of 3,000 health workers. So some of our next steps, we're now hoping in this next quarter to reach 1,500 maternal and child health facilities in Somalia, which will give us 60% coverage across the country. We would love to, of course, replicate the work we're doing in Somalia, ensuring that other contexts have some of the lessons learned and not necessarily just scaling impact. We've had many opportunities to go into different markets, but sometimes it's just really what worked and what didn't work, and finding the local partners in those contexts to be able to accelerate that impact. And of course, our solution is customizable as well. So it's already designed during Yemen's COVID response. We were able to take the work we were doing in Somalia with some of our social behavior change messages, and the national government there replicated those programs. So sometimes, of course, it's important to piggyback off of programs that work. And we're working with the government as well on implementing some AI. We talked about the logic models and support systems in Somalia. It's very difficult for a health worker who has less than 1 to 5 minutes, right, with an interaction. We want to make sure that we're able to incorporate ethical AI when possible. And sometimes, everyone's rushing towards AI, right? But it's really understanding how does that streamline into government workflows as well without being too disruptive. So we're very intentional around our journey around that. And if anyone's interested in learning more, I'd love to chat through that after this session. Ready, thanks.
Right. Now we've got Mentor. Adrian.
Yeah, no, I'm not, we're looking very serious out there.
Serious people.
Serious people, serious subjects. So I'd just like to start by saying that I'm actually filling in for our Syrian colleagues who unfortunately have not been able to make the journey to actually present this presentation on the work we're doing in Syria for the control, predominantly for leash biases. And so I've got a few words down, so forgive me if I refer to my notes because it's not my speciality, but I shall do my best anyway. So the Mentor Initiative has been operating in Syria since 2013, predominantly in disease control, and right the way through the conflict period, we were running vector control activities, mainly built around IRS and obviously clearing of sites that have been damaged during the war, which is the predominant area where sandflies essentially make their home, which is see the increased prevalence of cutaneous leishmaniasis in Syria. So this essentially is driven by the conflict and displacement, and obviously poor healthcare access impacts the problem. So traditional vector control tools like spraying and treating nets are difficult to use in temporary shelters and with mobile populations that you obviously see during the war. So essentially, we were looking at what the problem was and how to deal with that. So we had been piloting a product, spatial emanator, working with a commercial company, S. Johnson, America-based company, and we've used this for our operational research in Yemen, Syria, and northeast Nigeria. And so we moved to looking at a new solution. So these devices contain translucent, which is essentially a repellent, and it also have a knockdown effect on various vectors, mosquitoes, sandflies predominantly for leishmaniasis. And so we introduced two main products. One's called Guardian, and the other one is called Shield. And so the unique innovations lie both in the technology and the hybrid delivery module for this. So we know it reduces the incidence of sandfly populations. And on top of that, it is WHO recommended, which is always an advantage. It was one of the problems we ran into in the early days because it hadn't received approval from WHO at the time. But now, thankfully, as of last year, it does. So this delivery model essentially combines humanitarian distribution with a market-based distribution. So it's freely distributed to displaced and vulnerable populations in camps. And at the same time, it's been introduced to local markets via wholesalers and retailers. So households that can afford the products can purchase them locally. And using this model, we've looked to build a sustainable distribution ecosystem beyond humanitarian aid. As we know, the aid and funding in the last year has become increasingly difficult. So the long-term vision is to shift spatial repellents from a humanitarian-only tool to a sustainable public health solution. So this integrates products into the retail networks, strengthens supply chain, and reduces resilience on the humanitarian funding. So it ensures continued availability after the project ends and creates potential for replications in other conflicted regions. So as I say, the distribution is free to vulnerable communities. It's affordable retail sales by wholesale retailers. SCJ made this particular tool available at cost. There is no profit involved. And it has proven impact. So thousands of households have reached through the humanitarian distribution and also the retail introduction. So it's highly scalable. And it can be used in many other fragile contexts with similar vector control situations. So in conclusion, spatial repellents offer a practical, scalable and sustainable method to protect vulnerable communities from vector-borne diseases. And the combined humanitarian market model can also transform access to prevention tools in fragile settings. Also to add, within the sales in the commercial sector, this money is then set aside and then reinvested into the ministries of health. In this way, we found a way of being able to support the health facilities by the sale of the product. And hopefully it represents a new way to ensure long-term protection to reduce disease and transmission.
Thank you, Ian. Right.
Thank you, Ian. Great. So I'm Cassie Henderson. I'm from Mom Incubators, one of the innovations supported by Grand Challenges Canada. So I think it'll come as no surprise to anyone here that caring for neonates in humanitarian crisis settings comes with its own set of challenges. Princess Sarah mentioned that 60% of women who die in these settings giving birth. There's also the 50% approximately of newborns that die in these settings. We also know that rates of preterm birth and low birth weight babies also increase in times of crisis due to maternal stress and malnutrition. One of the important things for these babies in particular is keeping them warm. So we know that for every degree of temperature lost by a baby, the risk of mortality increases by 28%. Alongside KMC, or kangaroo mother care, incubators play a really important role in helping to keep babies warm. But in humanitarian settings and crisis settings, there are challenges presented by the damages to health infrastructure. So conventional incubators require stable power, they require highly trained staff, extensive maintenance, all of these resources which just aren't available in these types of settings. They're also bulky, and that makes them difficult to move when conflict shifts in different locations. Ultimately, this means that access to life-saving and functioning incubators is limited in these settings. So at Mom, we're trying to change this with a product that is designed specifically for these challenges in mind. So this product is clinically tested and proven to be as effective at providing the thermal care that every baby needs. It's also fully regulated. It has a CE mark and FDA clearance. It's been built to be easy to use, to clean and to maintain, because we know the healthcare workers there are burdened beyond belief in terms of their access to time and things like that. It's also, as you can see, much lighter and smaller. So at 20 kilograms instead of 100 kilograms, it's much easier to move around, just to get to the places in the first place, but also to move when conflict shifts. So this means that it can keep being accessible and with its portability to those that need it most. It has a built-in backup battery. That means that it can withstand power cuts when we know there's fluctuations in power access. It's also got built-in surge protection for those not so robust power systems. Finally, we've also designed it to be easy to repair, so that if anything does go wrong, we can keep it out of the equipment graveyards. We've just focused on the core essentials so that in just a few minutes, you can have everything you need to help an infant not only survive. So where are we on the scaling journey? Because that's what we're talking about here today. So this map shows in green where the incubator is currently in use across 7 different countries. Blue is where we plan to go in the upcoming year. The use is across a variety of different settings. So in our home turf of the UK, it's being used in the NHS, all in traditional NICUs, more neonatal intensive care units, but also in transitional care to allow mom to stay close to baby and be cared for right next to her and prevent that the lack of bonding between maternal and newborn separation. In Kenya, it's allowed a rural hospital to expand its caring capabilities so that it can prevent risky transfers down a dirt road multiple hours, many of the babies which didn't previously survive this. In Ukraine, it's allowed clinicians to move their NICU facility from the hospital down to a bomb shelter, unfortunately, in the case of air raids. Throughout these different settings, we work closely with the health providers and the implementers there, not only to support the introduction of the system, but also to learn from them and to learn for future iterations. It's partnerships like this with our implementers like International Medical Corps and funders like Grand Challenges Canada with the transition to scale and scale-focused funding that make our scale possible. So in conclusion, we think that scaling health innovation and emergency context requires products that are designed for the context, but that are also supported by strong partnerships. Thank you for listening.
Right, now we're going to have a panel. I'm going to hand over to Zaina to moderate.
Awesome. Thank you, everyone. Thanks for the great presentations. I feel like every time, I mean, I know this portfolio very well, but like every time I meet with these folks, I learn something new. And I think that took you 20 seconds to build it. So I lost track. I got a bit distracted, but I think the last time I saw James build it, it took him about 29 seconds. So like, you were very efficient. And I think just, well, she is an engineer. And I think that just really speaks to like the value that it brings to some of the most complex settings where time is of the essence. So thank you. And thank you to the rest of the presenters and to Kaiser over there online for your wonderful presentation. So we're gonna pop into our panel discussion. So I'm just gonna kind of like point some questions to the various speakers, and then we'll turn the mic over to Ian and we'll do some Q&As. I'm sure many of you may have some questions or want to know more about these great innovations, or how you can scale them and how you can put them in your kits and how you can deploy them to the various countries that you are working within. So first on the hit list, Khalid. You've been scaling your work in Somalia, and you mentioned primarily with UNICEF, which is a really exciting achievement. And there have been others too. Can you talk us through what the journey has been like, and what recommendations you would have for organizations trying to partner with UN agencies, the government, and others?
So our partnership with UNICEF was an exciting one for several reasons. One, prior to that, we were working with close to 45 different partners, all that had different health priorities, and oftentimes as a lean organization, sometimes there is that push and pull and you can get moved around in different directions. Also, the context of Somalia in which we work in, there's a lot of sometimes semi-autonomous regions or decision makers or decisions that are happening at a very district level, and sometimes that information is not really channeling its way up to the technical working group. So UNICEF, for us, when we were thinking about partnerships, UNICEF was very powerful because they had that convening power. They had that relationship with the federal government, but as well as all the different state levels as well. And that they were able to really ensure that the system was not just adopted, but was really actively being used. And the reason that they were able to do that is because they were chairing the nutrition cluster, which means that a lot of the RUTFs that are within the clinic, they were able to tie it to performance metrics as well for health workers. So it's not just a typical pilot that we've really were working with in the past, where set NGO has a terms of reference and you apply for it, and sometimes unfortunately they just need to like get some resources out and get something that's like sexy out in the market. And innovation sometimes is just that for a lot of partners, where UNICEF was able to really think more systems level, right, in terms of what can we invest in that can really help close the gap. Also 200 facilities were shut down with the funding cut with USAID. So there was not only that level of how innovation can reach more mothers and children in a more efficient way, whether that's through our social behavior change messaging or the proof of concept that we were able to build with other partners, but it was also how do you position this to unlock funding with USAID. So UNICEF was able to go to USAID and say there's actually an innovation that's able to track all the supplies from the warehouse all the way to the mother and the last mile. And it was our innovation that was helping support unlock some of that funding. So sometimes innovation is not really only primarily around helping solve a health crisis, but also is unlocking funding that can help sustain an entire system, and we're able to help contribute towards that. But also from a government side, it's important when you're thinking through innovations is that we're no longer, at least in my opinion, is chasing pilot projects, or it's a distraction, and sometimes you're not able to sustain those efforts if you go in with that mindset. We're thinking about how do you disrupt systems, but also how do you integrate your solution into health systems. And in order to do that, you have to understand the priorities of governments, of course, at a national level, and sometimes entities like UNICEF can help position you at that table. Especially if you're a local innovator, it is very, very challenging to innovate, sustain, and maintain relationships at a district level, build teams, right? Cultivate that culture of really trying to drive partnerships, and then manage the politics at a national level. It's a completely different ballgame. Sometimes I'm like pulling out my hair, but it's what really sustains the work. And because UNICEF was able to unlock some of that, now we're able to sit on a table as peers with the government, as peers with UNICEF, not on just like one side of being a recipient of a consultancy or a contract, but being thought partners and real true partners on the table and saying, this is what works for our innovation and this is our organization, or perhaps maybe this piece of what you like for us to innovate on is not something that we'd like to participate in at this time. So it's been an interesting partnership, and also, of course, the scaling journey. You know what their priorities are now in the pipeline for other countries, and they're able to. No one wants to reinvest in something that is already working in one context. So now, how do you maximize the impact globally? And UNICEF is helping us think through that. So we're entering some very exciting markets soon. I can't really mention now, but it's really partners
Big
like
news to come, I hope,
big
at
news
some
to
point.
come. But it's partners like UNICEF who are able to help us, as long as others, right? It's UNICEF came in at a later time, so not all credit to UNICEF, but they're one partner amongst many others. It's really the local partners of 45 that we work with, whether they're local Somali nonprofits and organizations that are managing clinics in country that are helping really accelerate the work on the ground as well.
Sounds like an important scaling partner in the value network.
Absolutely.
Yeah. And you mentioned something about sexy innovation. I think one of the other speakers also mentioned this, and I think this is a really good segue into the Mentor Initiative's work, only because like having worked in the innovation space for quite some time now, there's often this myth that innovation is a cool piece of tech. I mean, it is in your case, and in Zeid Kahani's case, but it doesn't have to be technology. It doesn't have to be a cool, sexy, shiny thing. And I think one of the things that I love about Mentor, and I've always loved, is it's literally a piece of paper. And maybe I think you have a demo there. And I think you just need to show through like how simple innovation is. And, you know, at Grand Challenges Canada, we're often trying to like myth bust this like, you know, myth in the sector that like it has to be this sexy, shiny new thing. It's literally a piece of paper that is saving lives, that needs to get into kits, that needs to get deployed, that needs to get into shelters and places. So, you know, innovation can be sexy, but it can also be a very simple piece that can transform how we approach humanitarian response. So with that, Adrian, your innovation is actually one from the private sector. And you mentioned SC Johnson. Tell us about how that arrangement came about, and what lessons do you have in partnering with a large corporation for humanitarian health needs?
Tricky question, but anyway, so our partnership with SC Johnson came about. We were running trials for them in humanitarian crisis settings. I have mentioned earlier on, we were in Yemen, Syria, and northeastern Nigeria, in Borno State, where traditional tools weren't working. Nets, as we all know, due to their chemistry, become less and less effective, and also they're used for a multitude of other uses. And so talking to them, they had this commercial product which they weren't really sure what exactly they wanted to do with it. They knew that they wanted it to be essentially not for profit, and they wanted to find a way of getting this out into the marketplace and to prove that it worked. So they approached us about 5 years ago. Sort of talks about the journeys, and you were mentioning that sometimes these things take quite a long time. And we originally started with this small. I mean, the chemistry in it is smart. But it's not as a product. It's very simple. And this one, Shield, essentially when we first piloted it in the programs, essentially lasts a month. And essentially what you do is just peel it out and hang it in the shelter. Guardian, which is a much more robust, is in the slide, is a much larger piece of plastic, and that's will hold up for 12 months. So essentially they are very light, they're easy to distribute, they don't cost the same amount as the large logistics does to distribute nets or large-scale IRS programs, and so from that they're scalable in terms of how much money it needs to get them where they're needed. And I think we learned early on that it had to be a very open conversation where, I guess, Jay, that they trusted us. We had a lot of input on what worked, what didn't work necessarily, and we moved this forward to where we are now. So and in fact, with WHO approving it last year, and that was because I think in us they found a partner that could actually distribute it and scale, improve through operational research. In fact, it worked, and I think that's for them. It worked both ways. It was a win for us, and it was a win for them to get a product they weren't quite sure what to do with to get it out to the market.
Thank you. Thank you. And Sikander, there you are. I mean, we've got some really good examples here. Scaling journey through the UN, scaling alongside in partnership with the private sector. And I think Zeid Kahani is another sort of example of, well, one, their story has been one of rapid growth across Pakistan, which you heard from Sikander earlier. And through that, you've partnered with insurance companies and the government for this. So could you compare and contrast partnering with the private sector and the government?
Yeah, sure. Thank you for the question, Zaina. So this is true. Engaging with these kind of power partnership has helped us grow exponentially over these years. But when we talk about the private sector and the government, we are talking about two very different kind of stakeholders who offer very distinct advantages and challenges when you work with them. In order to compare them, what I feel is that we can look at 5 strategic dimensions to compare them. The first dimension that I feel is the difference in the scale and reach when you work with these two kind of stakeholders. When you work with government, what they want is to reach the masses. For example, when we work with the government, when we negotiate with them, we talk to them, their ultimate goal is to provide healthcare access to all the population. Whereas when you work with private sector, what they want is a focused approach towards particular customer segments. As an example, when we work with insurance companies, what they want is to have the corporates with them to provide a healthcare benefit to them, provide doctors in 60 seconds to them, and have their employees to be happy. When we look at the second strategic dimension, is the speed at which you can move within these institutions. When we talk about the government, governments are very slow because their structure is very bureaucratic and slow. So you have to be very careful and you have to be very cautious when you're working with the government, and you need to be very patient. And this has been the case with us. We have been trying to get a lot of projects with the government, but those projects took time to materialize. But eventually they happened and helped us grow exponentially. Whereas when you talk about the private institutions, things in those institutions move faster and they are also very flexible. Then when we talk about the flexibility, the third dimension comes in, which is the innovation and the flexibility. Government, being old school, what they want is just the delivery in a way that they want to be delivered. Whereas when you work with private institutions and you make them understand that there are multiple ways that a particular value can be delivered, they are open to it, they are flexible. Just like in case of GCC, we have been very open, we talk to you guys, and GCC has always been very flexible and has always allowed us to be innovative with our solution. Whereas when we talk about governments with a rigid structure and too much regulations, they restrict one's capability to innovate. Again, another dimension that we can look into is the social impact. When you work with government, the ultimate goal is to make a social impact. It does not matter how much burden is being placed on the government itself. Whereas when we talk about private institutions, what they feel is it is very important to make innovations sustainable so that they do not eventually become burden on the government or particular kind of funding. One very important dimension that we feel is very important for growth of any innovation is the financial liquidity. With private institutions, when the liquidity is available properly at appropriate times, whereas when you work with governments, the process is so slow that the delivery of that liquidity gets slow, which makes harder for innovations to move ahead and move with the ultimate goal of providing value to the masses. Like there's a sentence, I would say there's a phrase: with private partnerships help you move fast while governments help you reach far. So maybe this sentence summarizes in a crux how these two stakeholders differentiate from each other.
Thanks, Sikander. I like the way that you put it. And I think it goes back to Ian's earlier point about Sayana Press. What did it take them 10 to 15 years to really see the potential for impact? And that also speaks to a lot of the work that GCC does. Is, you know, we like to see, we of course want to see impact. As an impact first investor, we want to see impact to that first step. But really, that potential is unlocked in the later stages of the game. And I think
Exactly.
you touched on that point as well. So, Cassie, hello. Your incubator is now in use in 7 countries across a variety of contexts. Many of your implementations in humanitarian settings have been made possible by partnerships with MNH-focused NGOs. How did these partnerships come about, and what lessons have you learned along the way?
Thanks, Zaina. So I think with Mom and with the incubator, we tried to build in the foundation for the partnership from the beginning by working with the NGOs to understand the context alongside the clinicians to understand the clinical need. And then from there, our partnerships have been kind of driven by the need on the ground. So in some cases, our partners have come to us with a need and looking for a product that fits that need. In some cases, we've heard about a need and gone to find a partner. And so it's kind of been both types of partnerships that have formed. I think we've learned a couple of lessons along the way. One of those is that you can lean into each other's strengths. So we're good at making a device. They're really good at implementing and delivering healthcare. But we try not to be siloed when we do that, but to learn from each other along the way so that we can make our next partnership more efficient and stronger. Lesson number 2, speed is important. So these contexts are changing all the time, where you can be flexible and where you can move quickly. That actually has a lot of benefit to it, especially in these contexts. And lesson number 3 is I guess similar, kind of to be flexible and to work with each other and have open channels of communication so that you can build that strong relationship that makes the basis for a strong partnership.
Awesome, thank you. Khalid, I have a question for you. You kind of touched on this, but different partners and customers want different things. What are they asking from you, and how are you addressing it through your innovation?
Yeah, so I think working in a context like Somalia, where there's a lot of different partners that are helping the government fill critical gaps, whether that's health systems or managing clinics. You know, in Somalia, 100% of facilities are owned by the government, but there's operating managers who are often NGOs. They all have different health programs, and oftentimes you need to be kind of the facilitator in terms of saying, you know, is this aligned to government priorities sometimes? Because even though the paper registers in the clinics are all Ministry of Health paper registers, the delivery is very different for different partners. So we get all sorts of requests. I think as we navigate the system and really strengthen our relationships with the governments across all levels, we go to them for approvals oftentimes and say, you know, this is partners requesting of this. Does this align to the long-term national planning of the ministry? And if that seems okay, we'll then tailor our solution to really meet those needs. Sometimes they're really great requests. For example, 3 of the implementing partners that are really large-scale NGOs asked us to align our innovation with their procurement and supply systems, which we were able to unlock. So our system has APIs and technologies that not only are integrated with the national warehouse, wheelhouse, which is DHIS2, the District Health Information System, which is very important for scalability, but every partner also has their own supply chains where they're able to manage the vaccinations or in different commodities. And as an innovator, you have two choices. You fill that gap, so you add a value add for the NGO, or do you allow for maybe another innovator or another additional solution to come into the market, which creates sometimes duplication and fragmentation. So you're kind of stuck in this really hard in a rock place where you say, do I take on more? But I think the bottom line for us is it something that will advance our mission and the technology speak to each other within a national framework of governance?
Awesome. And maybe what I'll do, I mean, we've got 20 minutes left. I want to pause here. I have a lot of questions that I could be asking the panel, but I don't want to be self-serving either. And I really want to let's take a little open up on the floor, take a few questions just to kind of see what others, what is this panel sparking in your minds? What are you finding particularly exciting of these innovation teams? Where do you want more information? And do you have any questions? So maybe I'm going to stop my line of questioning for a moment and pass the mic over to the floor and see if you've got any burning questions. Maybe you want to help filter through.
Chris, I have one. Like, you have a partnership with UNICEF, which is what most people crave. Where did that start? Was it the Office of Innovation? Was it a country office? Was it headquarters? How did you form a partnership with UNICEF?
It's a very interesting question, because I remember year 2 in our innovation journey, I actually submitted this proposal to UNICEF because I thought, we've been doing this for 2 years, we know the problem, they have to, of course, take it on. And I look at that proposal like 10 years back and I say, oh wow, that was really not what it could have been. It was UNICEF who actually went into a maternal and child health clinic 5 years into a runway that's seen it in a real world setting. And instead of sometimes this proposal that you submit and you think it's gonna land on the right person's desk, it was them that they seen the impact. They spoke to the mothers and children, they spoke to government, and they thought, oh wow, you're doing this within the immunization space. We need technology within the nutrition sector. Could you adapt the solution? And then, of course, there was an RFP that came out, and we were invited, as well as many other innovators who submitted, and we then were secured that contract at the time. 3 years later, we're now working with them within 800 facilities. So I think sometimes it's, and when they see it's interesting because when they see the technology in a clinical setting, it was GoFundMe, $10 pins that funded us to do that bootstrapping. And today now a partner like UNICEF is streamlining our innovation within their programs.
Hi, my name is Nathan. I'm from MSI Reproductive Choices. Thank you so much. This is super interesting. I was questioning what factors went into your decision making as innovators and where to scale next in other contexts, and beyond it was a donor interest or there was funding there. I'm really interested to hear that.
Who wants to take it first?
What factors went into your decision-making process on where to scale next?
So I think I mentioned it a little bit in what I was talking about with our partnership. So it comes really, in our case, from the need on the ground. So where there are access and needs and when it comes to incubators, but it's also come through opportunities like you were talking about, where someone's had a chance to see the product in person or to hear the testimonial of use, and then where partners have the right resources in place to scale. That's kind of some of the factors that have been involved in where we've chosen to go.
Anyone else want to chime in on that? What kind of weighed in on where to go next or where to stay?
I think as far as spatial emanators go, I mean, for us, I think the proof of concept in Syria that it can work in humanitarian crisis in a period where funding has become very scarce, and partnership with commercial companies as another way to find to be able to deliver these interventions. I think for us has given us an idea of other humanitarian crisis areas that we can now expand and work, try and move that model across. So I think, you know, at the moment we're in the process. We are currently operating in Gaza, but we fully expect to see the same increase in leishmaniasis, both cutaneous and visceral, in the months to come, because the situation is very similar to what was happening in Syria. So I think for us, the proof of concept for this will make us look at other humanitarian contexts where we have programming we can try and leverage from the private sector as well, to try and fill some of these gaps that are being left with the US government in the past.
Any other questions from the room?
Yeah, hi, I'm Hannah Murphy. I'm consulting for WHO, but also developing a health communications for refugees and migrants. I am really interested in how much co-design has been a component of your development process with the people who are using your services and products, and what kind of challenges and opportunities you've seen in following those processes or not following those processes, because they're very complicated in these types of contexts, working with different vulnerable groups with many different kind of factors around doing that ethically and safely.
Any other thoughts from the room? Questions?
Does someone want to go for that one?
I mentioned some of our approach to human-centered design thinking.
Yeah.
At the very start of our innovation journey, we actually were very fortunate to come across a fund by IDEO and their leaders in human-centered design thinking. And the challenge was called Innovating in the Maternal and Child Health Space, and was funded by the Gates Foundation. And we were bootstrapping, we were very scrappy at the time. It was actually our first grant that we've received, and it couldn't have been a better grant to start your innovation journey, because it allowed for me to travel to 7 representative parts of the country. And the only report we had was to fail and reiterate. There was no 50-page report. Sometimes we have to do that, and that's important too with grant challenges. But also with IDEO, it was literally speak to people and rebuild. And so we've done 3 things through that process. Initially, a lot of our innovation was on that Toshiba laptops that I was mentioning. We realized we needed Samsung. We needed to make sure that our messages were not only in SMS, but could be also in audio messages. We also then moved into a second funding stream prior to grant challenges. It was also global affairs funded, called the Fund for Innovation and Transformation. So we had 2 human-centered design funds back to back. And through that fund, we were able to then take what we've learned from the IDEO and then now take the messages and audio that we were sending to now be translated to 300 dialects. Because within Somali, there's very many different variations of speech. One really interesting insight that we've learned was when we were speaking to participants in our program, we were sending messages at 8 a.m. because our assumption was that mothers would love to get a message of their child first thing in the morning. We realized that 80% of participants said, no, that's not working for us. We want it later in the evening or closer to the night when our house duties are, complete. Have some time to digest our message. So we were able to tailor our messages around that time from that fund. And now we scale those messages to UNICEF at scale, as well as our grant challenges back fund. So I think a part of the human-centered design approach is not just learning from one grant, but also applying those lessons within the larger system and really being able to scale some of those messages.
Thank you. I think Sikandar wants to
go ahead, Sikandar.
Yeah, so I think the question I was trying to address to was the previous one before this one, which was around long-term sustainability, I guess, if I heard it right. The volume was a little low. So what innovations should look at is something that they should be working in a way for an innovation to bring in some commercial revenue as well with the social impact. This is something that we have looked into, which allows us to be more dependent on the long-term growth rather than just being entirely dependent on donor funding.
Thanks for that, Sikandar. So the importance of having a sustainability model.
Exactly.
I wonder if I could also pose the question around co-design. I mean, I know Mom Incubators has gone through various iterations, and there's been some lots of user-informed adaptations. I wonder if you could speak a little bit, Cassie, to sort of how the evolution happened and that kind of co-design element of the work.
Yeah, I mean, I think there's kind of like the strict definition of co-design, right, in terms of like participatory design and things like that. And I think probably the incubator was more like user-centered and human-centered design, like Khalid was talking about. So working with clinicians to understand their clinical needs and the way that they care for babies and how to make that easier to do. But also context appropriate design. So working with the NGOs, like I mentioned, to understand the context for use and what that means for the design. There's less opportunity for, I guess, some of the parent interaction in that sense. But we do find in the NHS, for example, like that maternal newborn bond is something that's being really prioritized, and patient feedback we get and around ease of use and things, something that we are constantly monitoring and thinking about in terms of how to integrate that feedback into design. So it's definitely been an iterative process, looking both at kind of like the requirements you need to meet as a medical device, but more importantly, the user experience and how to make that as easy and as friendly as possible. And so all the midwives will say in the NHS that all the parents talk about how friendly it is or things like that. And I think that's something we found important in terms of the design process.
Thank you. Any other questions from the room? Thoughts, reflections?
I just have a quick question. Thank you for the discussions. My name is Tutu, and I work in the conflict-affected areas in Southeast Asia, including Myanmar, with digital innovation. Just have quick questions on your products and your innovation and the scalability. So I was just wondering if you have model that can be applicable and used in a very low connectivity area, and also for communities with different digital literacy background. Yeah.
First up, Khalid?
Yeah, so my understanding is like if the innovation or the process could be adapted to other contexts, is it specific to telecommunication or sorry?
Like your model, and then what you also mentioned about sending SMS or just building the system itself, would it be applicable for area with very low internet connectivity, such as in refugee camps and IDP camps?
And maybe if you could speak to like how you sort of bridge that gap in Somalia, knowing that there's often low connectivity areas and also this element of digital literacy. Like, how did you overcome that, let's say, barrier in scaling your innovation?
Yeah. So in Somalia, one of two things. Our system, of course, we knew right off the bat had to be offline first. So we knew that Somalia on the continent has some of the world's best, you'd be surprised, internet connectivity, because a lot of payments are for livelihood are done through mobile devices, and about 90% of the population are connected to a device. But that's not to say that the messages that we would send would be read by every mother. So we had to ensure that the text within these Motorola devices, how much of our message could be fit within the screen. So now if you wanted to personalize a message and say the mother's name, the child's name, because that will drive them back to a clinic. Part of our human-centered design process, we've learned things like ASC, which is abbreviated for Assalamu Alaikum, and saying the mom's name, also saying the child's name. You also want the medical record number in there, so when they go to the health facility, they're able to search the record within the tablet. Then you also need a behavior message to shift behavior to drive the mom back to her next appointment. So we had to really do a lot of tests to see how many different phones are available in the market. One of our assumptions was that a lot of mothers within the maternal and child facility do not have an iPhone. So sometimes the assumption is flipped, because you're always told designed for what would be the typical profile of a mother visiting a clinic. We've learned that's not the case. A lot of mothers actually did have iPhones and Android devices that were sent from diaspora communities back home. Somebody's visiting and it's like, here, this is my aunt, here's a new iPhone, right? And they're able to use some radio channels with these devices. So we had to find a medium in terms of how many characters would be fit into the device. So that was one approach. I think the second question was around scalability to other contexts. Is that right? I think maybe some of my other colleagues who've actually entered different markets with their playbooks to other countries could address that. We still haven't scaled outside of Somalia. I think our strategy now is do that, and we'll scale over time. But maybe someone else can contribute.
Yeah, I mean, I think in our case, we work and rely heavily on our local implementing partners for the local knowledge and what works in their system, and focus on delivering kind of essential core of the care in that context.
Awesome.
I would like to add here something.
Oh, yes,
if I may.
go ahead.
So the challenges are everywhere. What we think is challenges are everywhere, but what helped us with the internet connectivity and the literacy or the usage for the people being using the application has been adding a layer to it. For example, at our e-health centers, we have added a layer which helps those people who do not understand technology help them with the consultation, connect them with the doctor, and guide them throughout the process so that they are better able to provide all the details that they feel at the moment, and better able for the doctor to be able to give them a proper diagnosis and a consultation to them. As for the internet connectivity, now what we figured out was not everyone has internet access. Therefore, our aim was to provide healthcare accessibility to everyone. Therefore, we had e-health application or telemedicine helpline with us as well. So in case technology is not working out, so anyone can connect to that helpline and they guide you through the whole process and provide you the best consultation that you can have.
Thanks, Sikander. So we're at time. I think what I'm going to do is I'm going to pass the mic back to Ian to sort of wrap us up and close us out for the session.
Brilliant. Thank you. What was great about that session was nobody fell asleep after a very long day, and you were all paying attention.
We had a tough window.
Yeah.
So well done.
Windowless room, end of the day, a bit hot and stuffy. So thank you for coming. Thank you for all the panelists who kind of shared your experiences. Thank you to Princess Sarah, who's taking a call, I think. And yeah, just thank you all for coming. She's here, so thank you. And if you want to find any more about Grand Challenges and Sheik there, if you want to find any more about us, we're up there as well, and you can get some tools around our value network work on that QR code. But Zainab, thank you, and have a good evening, everyone.
Thank you, everyone. Thank you for having us.
Thanks, Sikander.
Sikander.
Thank you.